Hi, my name is Michelle Henry, and I'm with the University of Texas at Arlington School of Nursing. Today, I will be lecturing on a patent ductus arteriosus in the preterm infant. This lecture is for BSN students in the academic setting in a 4-year degree in a campus classroom. The age of the students varies from young adults, 18 plus, to about retirement age. The educational level is also varied. Some students are here for the very first time, and while others have previous degrees and careers. So let's first start off by talking about what we want to learn in this lecture. So let's go over the objectives. By the end of this lecture, the BSN students will be able to, 1, identify 2 factors to reduce the risk of a PDA, 2, describe 3 signs and symptoms of a PDA, and 3, list 2 treatment options for a PDA. So some of you may be wondering, what is a PDA? A patent ductus arteriosus, or PDA, is a congenital anomaly where abnormal blood flow occurs between 2 major arteries that are connected to the heart. Before birth, these 2 major arteries, the aorta and the pulmonary artery, are connected by a shunt called a ductus arteriosus, and this is an essential part of fetal blood circulation. This shunt allows deoxygenated blood to flow from the right ventricle and pulmonary artery, thereby bypassing the lungs and go straight into the descending aorta and umbilical arteries to become oxygenated in the placenta. Now, normally after birth, the baby's first breaths increase oxygenation and the pulmonary flow to the lungs, which initiates the constriction of the ductus arteriosus. And this typically happens within 72 hours. However, in some babies, this duct will remain open or patent, and this causes oxygenated blood from the aorta to mix with deoxygenated blood from the pulmonary artery, and this is known as the PDA. This congenital anomaly is considered a left to right shunt, where blood is allowed to flow backward into the heart or pulmonary artery and bypass systemic circulation. Now, a PDA results in diminished cardiac and respiratory reserve due to the high volume of blood that's being pumped through the heart and the lungs. This puts a tremendous strain on the heart and lungs and can cause pulmonary congestion, edema, as well as hypertrophy of the left side of the heart, resulting in congestive heart failure. A PDA is a common congenital heart defect, and it occurs in about 1 to 5,500 infants, and is linked with prematurity in infants weighing less than 1,750 grams at birth. It is also associated with several neonatal comorbidities such as intraventricular hemorrhage, bronchopulmonary dysplasia, and necrotizing enterocolitis. So if your baby has been diagnosed or you think that he has a PDA, they will start having certain signs and symptoms. First, they will have increased work of breathing. They'll have apnea, they'll have tachypnea, along with bradycardia, and definitely an increased need for respiratory support. They will have bounding peripheral pulses and a hyperactive precordium. They'll also have widening pulse pressures, and the hallmark sign is a murmur, and usually the murmur is pretty audible. So as far as diagnosing a PDA, the gold standard is the echocardiogram. Now, once this is performed, usually the doctor can definitely diagnose the PDA. As far as treatments go, there are 2 medications that can be used, indomethacin and ibuprofen. These are both COX-1 and 2 inhibitors that inhibit prostaglandin synthesis, thereby closing the duct. They can be given IV or PO, and they're usually given in about 3 doses. These medications may reduce elimination and increase serum drug concentrations of drugs that are excreted renally, such as aminoglycosides. There are also interactions with NSAIDs, anticoagulants, antihypertensives, and diuretics. They are contraindicated in cases of renal failure, thrombocytopenia, active hemorrhage, necrotizing enterocolitis, as well as sepsis. The efficacy goes, they are about 48 to 95% effective on the closure depending on the dose, duration, and method of administration. And randomized trials have compared these 2 medications and suggest that they both have about similar efficacy in duct closure and possibly reduced incidence of renal side effects with ibuprofen. As a last resort, the infant can receive a PDA ligation, and this is a surgery. A small 1 to 2 inch lateral thoracotomy incision is made where the surgeon is able to see the PDA and close it with a metal clip or suture material. So you may be asking yourself, can this be prevented? Is it genetically linked? Does it have something to do with the lifestyle? So prevention, environmental teratogens, and genetic factors of PDA are linked to the mother because a PDA is considered a congenital anomaly. A PDA is associated with prematurity, viral infections of rubella and CMV, maternal medications of anticonvulsants or amphetamines, and genetically affects females twice as much as males and linked to family members with a congenital heart defect. Prevention would ensure that the mother receives good prenatal care, including vaccines and a medication review with the physician to reduce the risk of prematurity that can lead to a PDA. So let's go over the key objectives of this lecture, and let's link it back to the objectives that we talked about in the beginning of the lecture. So by the end of this lecture, BSN students will be able to, 1, identify 2 factors to reduce the risk of a PDA. So we learned that the risk factors are prematurity, viral infections, maternal medications, and also genetically it affects females twice as much, and it's also linked to a family history of congenital heart defects. So having a meeting with the doctor to do a medication review to make sure the mom is up to date on her vaccinations, as well as maybe going over a family history of if there's any congenital heart disease in the family. So objective 2, describe 3 signs and symptoms of a PDA. We talked about there's going to be increased work of breathing, apnea, tachypnea, bradycardia, as well as an increased need for respiratory support. Other symptoms include bounding peripheral pulses and a murmur. And lastly, the third objective was list 2 treatment options for a PDA. We talked about having medication, which is the ibuprofen or indomethacin, as well as a surgical option to ligate the PDA. The outcomes of surviving a PDA without complications are positive with prompt treatment and follow-up. Rarely, once the PDA is closed, the infant may need to meet with a cardiologist, but usually once the PDA is closed, they are generally okay. So let's talk about some of the evaluation for this lecture. We're going to have a group discussion just to reinforce some of the key factors that we learned. Some of the questions I want you to think about is, how did this class increase your knowledge regarding a PDA? 2, do you feel comfortable teaching this topic to a parent? If not, what would you like to learn to give you more confidence? And 3, tell me how you would describe the physiology of a PDA to a parent. Then we're going to go into an activity of concept mapping, where we are going to go over a PDA and a concept map and see how all of those, the information related to PDA, how they all interact with each other and the relationships. And lastly, we will do a group post-lecture quiz in class, and there will be 4 questions to that, just also to evaluate the learning and to reinforce the key concepts. So this concludes the lecture on the PDA. Thank you very much for watching and learning with me today.